Good morning, and thank you very much for the introduction. I believe someone left glasses here. No? Thank you. Yeah, I think it's, first of all, I would like to thank all of you because I think it's very much important that you're spending your time on the weekend on this amazingly nice conference with great topics and discussion. So my name is Amina Rakhishiva, and I'm from Almaty, from Kazakhstan, and also represent a Heart Failure Association. So let's go. And this is my declaration of interests. And I would just like to tell you what about amyloid. And if you will go for the Congo rat staining, renders amyloid deposits as like a salmon pink. But overall, the amyloid is a protein folding disorder that with apple green, it's a biofingerprints. And we know that it's better to go this way. So we know the two types of amyloid commonly infiltrate the heart. And we are saying about AL amyloid or primary systemic, and also for transthyretin amyloid. And if we will go there, so we have to know that more than 30 proteins can form amyloid fibrils. And only two, as I already said, can really infiltrate the heart. And if we'll go, so if we're saying about what is really can infiltrate the heart, so primary or transthyretin, which is also divided to the hereditary and wild type transthyretin amyloidosis. So we just need to know, because this is something different with the therapy, with the management, and with a follow-up and strategy. That's why we do really need to look for the umbrella, but what is inside of umbrella, and we have to really be focused and dividing them. So we do, in 2021, the colleague of mine, Pablo Garcia, published a very nice position paper that is actually going and really giving us an opportunity what we should do step-by-step approach. So first of all, we have a suspicion of amyloidosis. And if we do, so we have to screen in case if we have a wall thickening, more than 12 millimeters, and also we do have more than one red flag or clinical scenario, so we have to go for the diagnosis of amyloidosis. And then we have to go for the treatment. But the treatment is also divided into two sections. First of all, it's a treatment of complications, and this is the most crucial. That actually, we are doing that every day. I mean, we're not stopping the treating of patients with amyloidosis if we do. If they have amyloidosis, we're still treating their complications. And what are these complications are? So if we will go deeper, the complications of and comorbidities in cardiac amyloidosis presenting in this slide, and this aortic stenosis, thromboembolism, conducting disorders, heart failure, atrial fibrillation, and ventricular arrhythmias. We are doing that. We are not stopping because it's a different, it's an inflammation disorder. No, we still have to treat our patients appropriately with each in overall complications and comorbidity. But at the same time, we have to use another step, another approach. It's CHOTS stop. Why? Because sometimes amyloidosis brings a bit different story to our treatment. So first of all, of course, we do need to prevent conduction disorders. We have to maintain a high heart rate, even if we need probably to pacemaker implantation, prevent cardiac embolism, which is also very common with cardiac amyloidosis. So we do have to consider anticoagulations. Diuretics, we have to adapt those to volemia, and even if our patient have a dyspnea, we have to be very careful with diuretics too. And we have to be very cautious with using beta blockers and with their agents that actually is reducing the heart rate because it can be dangerous. And I would like not to stop too much on treatment of AL amyloidosis, because actually this is, in the majority of time, in my country at least, this type of amyloidosis is treated by hemotherapists and with hematologists. But I would just like briefly to show you that they still also are going and developing the treatment for AL amyloidosis. But what for the trans-13 amyloidosis? And we understand that the new era is really coming up because we have a different type of pathogenetic therapy. And if we look here, we can either to silence a TTR gene by by cRNA and SOA, and either we can stabilize TTR by using tafamidis, acoramidis, and diflunisal, or we even can cleavage from the antibody from the amyloidosis. I would like first to show you, but already you know this data that they were presented earlier in 2018, the data by Professor Moore from Boston that showed that tafamidis, which is actually a stabilizer, it's reduced all-cause mortality of 30% compared to placebo. It's not only reduced, but if we will look for the longer follow-up period, and here the data shown for 58 months continuous tafamidis group compared to placebo, we can see that the curves started even more from each other, and it was 41% risk reduction, and the number of deaths was 79 compared to 111 in placebo group. So it's really promising drug and agents for the amyloidosis treatment. It's also reflect and it's also impact for the quality of life and for the 6-minute walk test that is actually very crucial for patients with heart failure. And we can see that the curves, they're curves very distant from tafamidis to placebo, and we can see that it's sustained and consistently different, and then the NT-proBNP level also will be reduced and will be dropped with the tafamidis compared to placebo. Also, another thing is it's a subgroup analysis that show that NT-proBNP and high troponin will be also reduced by tafamidis, and we can see that on the left it's their level, and it's actually the yellow number. It's the NT-proBNP level more than 3,000, and we can understand that the number of patients with a very high level of NT-proBNP is substantially decreased with their using of tafamidis, and the same for troponin level, for troponin. But we also, when we are diagnosing their amyloidosis, we are using we are using a long speckled trickle, and we're using the strain. So the authors of these publications really saw that probably tafamidis will also reduce this, and the strain will be improved by the using of tafamidis compared to placebo. That actually was really confirmed by this study. And they also showed that the strain of, especially of left atrium, was reduced by the using of tafamidis compared to placebo, but not for the left ventricle. Well, it's also it's very interesting because, again, when we are putting the diagnosis of amyloidosis, when we are looking for we are looking for the SPECT. So the data here show that for 21% it was a reduction in tafamidis arm, under tafamidis compared to the situation that was actually before. Another very nice agent that was, again, it's a light to stabilizer. It's acoramidis, and acoramidis it's a bit different to tafamidis because of they're silencing only one agent, and this was very interesting when they presented the data during the EC Congress 2023. But they showed that actually there are. They presented the ATT attribute cardiac amyloidosis study, and they showed that the primary outcome was 13 months outcome that was a win ratio for the all-cause mortality, cumulative frequency of cardiovascular hospitalization, change from baseline in NT-proBNP, and 6-minute walk test. What they really showed, so that should be really a patient with ATTR amyloidosis. a wild type or variant, with a New York Heart Association class 1 to 3, which is actually positive biopsy or a scan, and light chain amyloidosis excluded if diagnosis was performed by scan. So what do we really look for? But what is important to see that all studies with amyloidosis, started to do not only with a double-blind control study, but they also opened afterwards. And the reason for that is a really good impact of these drugs, of the agents to amyloidosis patients. So this data that attribute studies show the highly statistically significant result achieved on primary and selected secondary endpoints. So we can see that the p-value was 0.0001, so it's a very statistically significant result compared to placebo arm. And what we can see that it also was true for each part of the cumulative endpoint. Despite one thing, despite that all-cause mortality was not significant in these patients. And so after the extension, open-label extension showed again the beneficial result of acoramidis compared to placebo that actually give us an opportunity not to stop treatment, but even so, we are really, patients on placebo arm switched to acoramidis, and it's really good for the patients. That actually it's showing here that patients who were switched to acoramidis, again, the results were also improved in these patients compared to placebo. Well, let's go back and let's look for the patisiran and vutrisiran, which are silencing agents. So patisiran, it's injections, IV injections every 3 weeks, and the Apollo B study design that was, again, so we are looking for the double-blind treatment period, and then it's extension for open long-term, and we understand the reason for this extension. So there was the patients were randomized 1-to-1 to patisiran group or placebo. And actually the data were available for 12 months for 181 and 179 for placebo arm. And what we do see, and actually, the primary outcome for the Apollo B, which included variant and wild type ATTR, actually, the baseline, the primary criteria was a change of a 6-minute walk test and quality of life. And we also can see that the curves were really, they were different in patisiran compared to placebo, and that was still, consistent for open label period of time. Another study with another agent, Halos B study that was presented in 2024, that is included vutrisiran, and actually this is a bit that make a story because it's not with with a daily or with a 3 weeks injection. It's a 1 and a 3 months injection, and the patients again should be really be eligible of the criteria shown in the left, and they really should be confirmed either by biopsy and by their scan, and probably confirmed cardiomyopathy and history of symptomatic heart failure. And what we will see, the primary endpoint is, again, it's composite outcome of all-cause mortality with recurrent cardiovascular hospitalizations, and secondary endpoints showed here. All our studies started to include not only a 6-minute walk test, but also a quality of life Kansas score, because the patients with amyloidosis are really suffering from suffering from inequality in their daily life and in bad condition of them. That's why it's really important for them. So the vutrisiran showed again the beneficial result, and actually we can see that it's 28% risk reduction for the primary outcome compared to placebo, and this was, for every single subgroup analysis showed the beneficial result for the vutrisiran compared to placebo. And what is also important, the extension that also was with the Helios B showed again the benefit result for the vutrisiran compared to placebo. Another one, it's again we're saying about a silencer, but this is a little bit this will make the story even amazing and fantastic because it's just one injection. And the data that is shown here, it's a first gene therapy result for ATTR. And the CRISP case 9 in vivo gene editing for transferring amyloidosis showed the really promising result. We do have to wait for the other results and for the other phase 2 and phase 3 studies. What is important to see here, so I would like also to go for the cleavage antibodies to cleavage amyloid deposition. And here, the phase 1 trial of antibody that of depletion of cardiac amyloid, it's NI006 of placebo every 4 weeks for 4 months. And it will be again the 4 months placebo control for ascending dose for patients follow-up for 8 months open label extension phase. So what we can see that actually, again, I mean, the drug is also promising because we can see that the cleavage of amyloid is really, from the baseline to 12 months follow-up, is really promising. And I think it will be something that will give an opportunity to be even efficient, to have all 3 agents in our practice. And also, if we will see here about exposure and also about NT-proBNP level, so they're also really reduced. So NT-proBNP and troponin level. So furthermore, there is the review that was published again in 2021 that we do have not only to find a proper treatment, but it's important to monitor patients and to monitor transtherapy and amyloid cardiomyopathy. So criteria for disease progression in patients with ATTR, and we have then to look for the clinical and functional criteria for laboratory biomarkers and of course imaging and EKG. And one marker from each domain provides the minimum requirement for assessing progression. What will give it? Is this a question monitoring? So I think it's really something that we have to go and have to be focused on because it's easier to look for the progression. It's easier to look for the call of action. So, and here it's just like a brief note of what kind of a treatment do we really have for amyloidosis. If we're saying about silencers, we understand that the TTR in serum will be reduced. If we are looking for stabilizers, we understand that the TTR level in serum will be increased. And here, it's not about TTR, but it's about amyloid deposition. So here we are looking for amyloid fibrils. So this is something really, I think it's crucial for the further steps. But what is important for the conclusion? AL amyloidosis are rare, underestimated and fatal multisystemic disease, cardiological diagnostic emergency, ATTR treatment, tafamidis, and a lot of new options are coming if we can offer them for patients because we understand it's very costly treatment. And we should not forget about ATTR and cardiomyopathy because they are frequent. And the evolution of targeted treatment options holds much promise for improving the outcomes of patients. Thank you very much for your attention.